Welcome, everyone, and thank you for joining us for the International Myeloma Foundation's Living Well webinar series. Today, we will focus on living well, ways to improve your bone health as a myeloma patient. I'm Robin Toohey, Vice President, Support Groups. Before we get started, on behalf of the IMF, I'd like to thank our sponsors for supporting this educational program. And tonight, that is Bristol Myers Squibb, GlaxoSmithKline, Janssen, and Sanofi. So you can participate during the open Q&A and ask your questions. Here are some instructions on using the chat box. If you have a question that does not get answered today, please remember you can contact the IMF info line, and here is the number, the phone number, and the email for you to do so. If you have a technical challenge, we're also here to help. And here's how you can either call the help desk at 765-633-4749 or send an email to helpdesk@medipix.com. So we'll also have a video replay available on the IMF website along with speaker slides. This is a great way to review the material, and if you belong to a support group, something that you can replay at your meetings. You can find this replay information and all other webinar replays at myeloma.org and simply click on IMF videos. It's also very important to us that we hear from you. At the end of this webinar, you'll have the opportunity to provide us with your feedback. Please take a moment to do so, as it helps us to know your needs so we can continuously improve our programs. It's now my pleasure to introduce you to our speakers. Dr. Beth Faiman began her career in 1994 at the Cleveland Clinic in Cleveland, Ohio, where she is employed and immediately became involved in the care of patients and their families living with multiple myeloma. She's also involved in clinical trials to improve numerous drugs to treat myeloma and remains an active member of the healthcare team in the diagnosis and management of patients with multiple myeloma. Dr. Faiman is also a founding member of the IMF's Nurse Leadership Board in 2006. And she is passionate about side effect prevention and management. We're also grateful to have joining us this evening Dr. Jens Hillengass, a professor of oncology and chief of myeloma and amyloidosis service at Roswell Park Cancer Center Institute in Buffalo, New York. Prior to joining Roswell, he was the deputy of the multiple myeloma section of the University Hospital of Heidelberg, Germany, the leader of its autologous stem cell transplant program, and heads of the Hemato-Oncological Imaging Research Group at the German Cancer Research Center. Dr. Hillengass is also a member of the International Myeloma Foundation's International Myeloma Working Group, where he co-chairs the Bone and Imaging Group. So at this time, it's my absolute pleasure to turn this program over to Beth Faiman to start us off. Beth?
Thank you so much, Robin. I really appreciate and am always honored to be invited to speak to patients about side effects, and even more so today with Dr. Hillengass, who is a co-chair of one of the most important groups in the International Myeloma Working Group. So today we are going to be focusing on bone health. This is one of the most important ways you can keep yourself healthy, and we'll give you some strategies and tips. One of the things I recognized when I started caring for patients with multiple myeloma was how many of them presented in wheelchairs and all hunched over, and now we have so many good strategies, medications, supportive care techniques to prevent that from happening. So now people can stand upright and tall as we treat their myeloma. So we'll go through the guidelines, and also review bone health is so important. Now, most of you on this call know that multiple myeloma is a cancer of the bone marrow plasma cells. The healthy plasma cells responsible for protecting you from getting sick, unfortunately, make one clone of an abnormal protein called a monoclonal protein. Those proteins will continually secrete cytokines, chemicals, and all different kinds of things that want to dissolve the bone and can attack the kidneys. And so treating that protein when appropriate is very important. When you have an abnormal protein in your blood or urine, this slide shows that there's really 3 different phases. The first phase is monoclonal gammopathy of unknown significance. Many of you here on this call might have MGUS or had MGUS before you were treated with myeloma. There is actually good evidence that shows even people with MGUS can have ongoing bone loss from the chemicals that want to dissolve the bone in the bone marrow environment, and we'll talk more about that later. That second level is smoldering myeloma. Patients with smoldering myeloma have a higher level of circulating proteins in their blood or urine. This is a perfect time to find out why, whether or not you as a patient are a candidate for a well-designed clinical trial. Because if your protein's just high enough that you don't quite qualify for a myeloma diagnosis, you still might be able to participate in a clinical trial. So we can find out when we should start treating patients and when we should just continue to observe. And then finally, active myeloma, that's the top of the tier. That's when you have CRAB, calcium elevation, renal dysfunction, anemia, or bone lesions. So you can see part of the myeloma diagnosis includes bone, and that's why it's so important to talk about. In 2014, as you probably know, the International Myeloma Working Group also suggested that if you had a bone marrow percentage of greater than 60%, a free light ratio of greater than 100 of this capital lambda, and a low creatinine clearance and an MRI with greater than 1 focal lesion, greater than 5 millimeters, usually found on MRI, and Dr. Hillengass will talk more about that later on, then those patients should qualify possibly for earlier treatment. Dr. Hillengass?
Thank you so much, Beth. Great introduction. Thank you so much for having me, and it's a real honor to give this talk with you. Myeloma bone disease, as you mentioned, is a very important part in myeloma, obviously, and as you can see here, what's going on in myeloma is that the myeloma cells are interacting with their environment. They are very depending on the environment. When we do research and we take the myeloma cells out of the environment, they oftentimes just they die, right? And so they need this interaction with other cells, and some of those cells are the bone eating and the bone building cells. All of us have those cells. They're called osteoblasts and osteoclasts. The osteoclasts are the eating cells and the osteoblasts are the building cells. So usually they're in a balance, and our body repairs itself by eating bone and then building bone at the same time, or almost at the same time. In myeloma, the bone eating cells, the osteoclasts, are overactivated, and that leads to this bone loss. And the osteoclasts, they are increased in number and in activity. So it's not only more, they are also more active. And that's important, especially when we look into how can we treat or how can we prevent further damage to the bone. The osteoblasts, the bone building cells, are more active, and this oftentimes happens in a very close proximity to the myeloma cells themselves. So there's a very close interaction between those cells. Osteoblast activity is usually normal in other regions or sometimes even increased, so showing that the body tries to counteract this overactivation of the bone-eating cells, the osteoclasts. And there is this theory, it's not, to my knowledge, it's not really proven, but there's this theory that when the bone is destroyed, that it builds a scar, because that's oftentimes a question that my patients ask me: if I have a lytic lesion, will it ever go away? So that's something that is still not really clear. Maybe you, Beth, know more about it, but I think it is difficult, and I will show later slides where I go into what happens to the osteolytic lesions later on. This is a very complex slide, and please don't go into any details. It's just showing you this complex interaction between the bone-eating cells, the bone-building cells, the myeloma cells, and the stromal cells, which are other cells in this area. And there's a lot of research going on, still going on. This is research, as you can see, from over 10 years ago. There's still a lot of research going on right now to figure out what's really going on, what can we do to prevent this destruction of the bones. We have done some interesting, a young colleague from Heidelberg who came to Roswell Park in Buffalo for 2 years, did really great work where we did biopsies of an osteolytic lesion, of these punched out lesions that cause all this trouble with fractures and pain and all that. And we did a biopsy of that, and we did a random bone marrow biopsy, as we usually do on the pelvis, as most of you, I guess, have experienced. And you can see maybe on the upper right side, we found that in the osteolytic lesions, there are more cells most of the time. And in the bone marrow, sometimes the cells are less. So just a mere amount of myeloma cells seem to have an impact on this bone-eating process that's going on there. And we looked with we call it deep sequencing. We looked what genes in the myeloma cells are overactive. So the genes are the blueprint of our cells, and certain genes can be up and down regulated. And when they're upregulated, this process that this gene is the blueprint for is more active. And what we found is that in some of these cells, in the osteolytic lesions, the bone turnover genes were very high. So we think that the myeloma cells have some genes activated that lead to this bone destruction, and that stimulates then this osteoclasts. So it's a very complex interplay of these different cell types, and this is what we still try to figure out. We are now looking into immune cells surrounding the myeloma and the osteolytic cells, and we see that there's even there an interaction between those cells. As we mentioned, myeloma bone disease is very common. Almost 90% of patients have some kind of lytic lesions in the course of their disease. 80% have fractures. It increases the mortality because there are things, obviously, patients who are in pain cannot move that much. They have a higher risk of thromboembolic events, blood clots, can rather get pneumonias because they cannot be active as they should be. And so there are a lot of things going on that are connected with the bone disease that are not even manifest itself in the bone, but in other areas of the body. But pain is obviously a big topic. Fractures, hypercalcemia is also related because these bone-eating cells get calcium out of the bone into the bloodstream, which then can cause other symptoms. For the diagnosis, and it was already mentioned by Beth earlier, we have different ways to diagnose the disease. And I could talk about, I would say without interruption, 5 hours about imaging in myeloma, because that's what I have done for the last over 20 years. We have done a lot of skeletal surveys for many, many years, right? And that was okay at the time when we had nothing better available. But nowadays we have more modern techniques. And there was a question in the chat asking about MRI. I want to go through those techniques briefly. The WBLD-CT is a whole body low dose CT, which is a CT scan of the whole body, no contrast agent needed. And that is the most sensitive technique to detect bone lesions, because CT is based on X-ray, and the X-ray is not going from one direction, just in one area from one side to the other, how it is the case in skeletal surveys, but it goes around the body. So we get a 3D image of the skeleton, because the skeleton, obviously the bone is very dense, and this dense bone kind of blinds out the X-rays. And if we do that from a 360 perspective, then we get a 3D image. PET-CT is giving a radioactive dye, which basically is sugar that's radioactive. And cells that are very active, like myeloma cells, eat up this sugar, and then it lights up. This sugar lights up in the area where we have this accumulation of the myeloma cells. And then we combine this with the CT, and then we have this benefit to see the bones. So a combination of metabolic activity of the cancer cells, finding them in the body, and then we can see if they have led to this bone destruction. And then why we do, if this is so awesome, why do we need MRI in the first place? And MRI is very sensitive. MRI is based on the water content of a tissue. Bone doesn't have a lot of water, so the bone itself is not very well displayed in MRI, but the bone marrow, which is inside the bone. And you might remember the steel needle going through your bone into the bone marrow. That's exactly where we have our bone marrow, which is the organ that builds our blood, but that's also the organ where the myeloma is actually sitting, because that's this interaction that I mentioned earlier, this bone-eating, bone-building cells, stromal cells, and all of that. That's a whole family of cells sitting there and interacting with each other. And this is a slide actually from Beth, and I really like it because it also mentions DEXA scans, bone density, which is very important in osteoporosis. When we get older, our bones just get a little bit weaker, and DEXA scan shows that. But in multiple myeloma, the problem is, as I mentioned, that oftentimes these lesions are very focal and punched out. And if you do DEXA scan of the left hip, you will not see what's going on in the right arm, right? So DEXA scans are interesting for a general diffuse loss of bone, but it's not really helpful for multiple myeloma or detection of lytic lesions. Coming back to this question about the whole body MRI, we would like to see a whole body MRI. Sometimes the insurance companies are giving us a hard time to get this, but there are good reasons to do that, because MRI shows the changes in the bone marrow before the bone is destroyed. Once the bone is destroyed, it still shows changes, but there can be changes before the bone is destroyed, and that's very important in early stages like MGUS and smoldering myeloma. In the low-risk MGUS, I don't think we need imaging, but in a higher risk MGUS or smoldering multiple myeloma, whole body MRI is very helpful. And the patient who asked this question talked about diffusion-weighted imaging. And just briefly, that's a technology that also measures the water content of the tissue. And it is very sensitive to detect changes before the bone is destroyed, which we obviously want to do. We don't want to see it when it's done. We want to see it before it's happening. The problem is that not every center, not every hospital, not every doctor's office has access to this diffusion-weighted imaging. And the patient asks here if there's a list of centers. To my knowledge, it's not. So you would have to ask your provider if they have access to this kind of imaging. And I just go to one last question regarding the diagnostics. It asks about PET-CT. And yeah, so that's a very specific question. So again, as a summary, CT shows the bone the best. PET-CT includes CT, so it shows the bone and it shows metabolic. The PET part shows the metabolic changes, and MRI is very sensitive to show changes before the bone destruction has happened. I think that's a brief summary of that. And then we have compared these different techniques, and we have found that CT is about 25% more sensitive than skeletal survey, because they did a long time ago, they did a study where they drilled holes into a bone, the bones of a corpse, filled it with water, did an X-ray, and they found that they had to destroy 50 to 75% of the bone until they even found any changes. So that's the reason why we would really recommend to use CT instead of skeletal surveys. And now I hand over back to Beth.
Thank you so much. This has been such a wonderful, thorough review of bone imaging, and I've been studying this for years, but the way that you've shared how these techniques are done has been very helpful to me, as well as I'm sure you on the line. So what do you do about these bones to treat them? You know, is it always going to be this ongoing damaging of bone? The osteoclasts are going to always nibble away at the bone. And, you know, it depends on how well controlled the myeloma is, number one, and how active these cells are. There are three main medications that are given to patients with multiple myeloma. The first one, according to the updated guidelines, is zoledronic acid. This is really now the preferred agent. It's also indicated for multiple myeloma-related hypercalcemia. So it's recommended at diagnosis to receive about 12 months of these bone strengtheners. And then at that time, the physician or the treating team can say, How well controlled is your myeloma? How bad are your bones? Do you have bone disease? And consider whether or not you want to give it on a quarterly basis, twice a year, once a year, etc. So that discussion goes between you and your treating team. Denosumab is a wonderful drug, and we'll talk about that in a moment and why we would use that. That may be used especially if you have kidney impairment. It's a monoclonal antibody against this rank ligand, and so that's really an important piece of bone turnover. There's all these different parts in the bone turnover process in that interaction between the tumor cells and the bone marrow microenvironment where these cells live. But the denosumab is very helpful. It's a shot in the arm, and it's given once a month in patients with myeloma. The important thing to remember about denosumab, if you've been prescribed it, is we can't just stop it. So there's some data that suggests that you can have reversibility of that bone building benefit. And there are some studies that say maybe we should have you get a dose of zoledronic acid before we stop, or just give it once or twice a year. And then pamidronic acid is one of my favorite old drugs. I actually just stopped recommending it routinely in the last 5 years. This is a drug that was approved in 1996. In 2002, there was a study that said it was non-inferior to zoledronic acid, which is then when we started using zoledronic acid for myeloma routinely. But anyway, there have been some quality of life studies in Europe that showed that 30 milligrams versus 90 milligrams really helped improve quality of life, decrease skeletal related events. So as much as I like the drug, I think that there are better drugs out there, which is what we're using these days. So let's go talk some more about the mechanism of action of these bisphosphonates. As much as I love these adorable graphics, I think the highlight of this slide is that there's an interaction between the tumor cells and the bone marrow environment. Look at this blue slide, the blue cell, that's your osteoclast. I call that the scrubbing bubbles guy. He nibble away at bone. And the osteoblasts, which are responsible for rebuilding bone, unfortunately in myeloma are silenced. And that's why we need these drugs such as bisphosphonates to wake up the osteoblasts to stimulate the growth factors to rebuild bone the way it should be. When you're looking at some studies that support the use of these bone strengtheners, this one study that is referenced from 2010 in Gareth Morgan, and this is from what's called an MRC trial. This looked at zoledronic acid versus clodronate, which was the standard of care at the time. And it showed that there was a significant improvement in people living longer when they were given zoledronate, which is the zoledronic acid, versus the clodronate, which we don't actually use in the United States. What's also really important to think about is the drug denosumab. I recently mentioned that we had this pamidronate or pamidronic acid from 1996, and then we had a study that said it was non-inferior to zoledronic acid. Now, in modern times, Dr. Nupur Raj and colleagues looked at a study and compared the denosumab, that shot that you can give monthly and then less often, versus the zoledronic acid. So this is what's called a non-inferiority trial. We're not trying to say one is better than the other, but both were really good at strengthening bones and decreasing what's called skeletal related events. And that's a common endpoint of these clinical trials, making sure you're not breaking another bone. Looking at the side effects of the denosumab, it's a different class of drug. It's a monoclonal antibody. It's not a bisphosphonate. So now we call these bone modifying drugs. The side effects are pretty similar among both of the groups. Most patients did pretty well, little bit of diarrhea, nausea, and constipation, but that can be seen in anything. Really, I try to advise patients to make sure that they're getting good dental exams and we're checking their urines, because these medications, the zoledronic acid can affect the kidney tubes, right? And so stay hydrated. The other thing we want to make sure about is that you're taking oral calcium. Now, many oncologists will say, don't take that because then if your calcium's high, what do we do? But when you're on drugs like denosumab or the zoledronic acid, it can drop your serum calcium down and make you tired and have other side effects. So talk with your provider about whether or not taking extra calcium supplements are right for you. I've seen some very low calcium levels. But again, some of the major side effects we worry about is the jaw necrosis. This was described years ago in a medical journal where it was actually breast cancer patients were coming into Florida, and they identified that patients were having more of this jaw complication. So it's important to make sure you have a good dental exam and good dental hygiene during this. We know zoledronate can affect the kidneys. I mentioned stay well hydrated, avoid nonsteroidal anti-inflammatories, and then acute phase reactions. That's kind of like some people feel like they're getting flu-like symptoms. So I recommend to take Tylenol on the days before or in the evening if you have that. This is a very graphic representation of the jaw necrosis, and in the early 2000s, I saw a lot of this. We weren't very good about recommending dental care. It can be a festering infection that doesn't clear. There are some studies in the late 2000s that were suggesting that antibiotics is how we should treat this, and that's still what I do, but I want to prevent it by good dental hygiene and a good dental exam to start. Going through these quickly now because I keep talking. I could talk for 5 hours about bone, just like Dr. Hillengass, but we have other things to do. Drug-related toxicity is something that we really worry about. So again, look at the dose, discuss this with your treating physician or your treating team. If you're going to have dental surgery or invasive dental procedures, make sure you have that discussion. Do you need antibiotics before or after, and is it safe? And then looking at the age and your race, there might be more risk factors for osteonecrosis of the jaw as well. Again, the duration of treatment, this is your alphabet soup of all the different guidelines. The important thing to know is that there is not a clear agreement as to how long. I saw some questions in the chat, how long should I be on it? Well, the International Myeloma Working Group recommends every month for 1 year, and then you can decrease the frequency long term to minimize your risk of this jaw necrosis and minimize your risk of kidney problems if you're on the zoledronic acid, but have that discussion with your treating team. Dr. Hillengass, back to you.
Yeah, I agree. I could also talk about, and the question in the chat are just great. They really reflect one short of two short answers. Zoledronic acid, the brand name is Zometa. That was asked several times. It's the same drug, just a brand name. And there's also a question about can bone heal? And that's exactly what I want to show in this slide. You can see on the left, it's a CT scan. It's basically a cut through the body with a CT scan. And you can see there's a big hole in this vertebral body. And then on the right side, after treatment, this patient had a regrowth of bone. You can see this whitish rim of the osteolytic lesion, and the body tries to rebuild bone. We did a study, a retrospective analysis, and in about 75% of patients, we saw these attempts of the body to regrow the bone. That's not a guarantee, and it's obviously large lesions take much longer, but since we have such good treatments, it is definitely beneficial. Then local therapies, obviously for pain and for fractures, what we can use is something called kyphoplasty. And kyphoplasty is when there's a fracture, as you can see in this cartoon. We can go in the, usually our radiologists or other surgeons can do that. And you can see here we go in with the catheter. We pump up a balloon. This is a very optimistic cartoon, to be honest. That the body becomes upright again is unfortunately not really happening. That the balloon basically presses the particles of the fracture to the rim of the bone to make it stronger there. Then we take the balloon out. And then what we do, we fill it up with bone cement. And I have spoken with a lot of people who do that actively. Our neuroradiologists do it. In Germany, it was actually a dentist who did it. He did a really great job. And what we see here is that this bone cement, when it becomes hard, it becomes hot as well. And this heat basically cooks the nerve endings, which then helps with pain. And we did an analysis later on to see, is this kyphoplasty really helpful? Another name is vertebroplasty. It's a little bit different technique, but very similar from the concept. And you can see here the bone around it heals. And we looked if the kyphoplasty has really a benefit, and you can see here the height of the vertebral bodies stayed high, like in the same level as compared to when radiation, which is another option to treat because it kills the myeloma cells and it leads to a local inflammation, which leads to a calcification, which is kind of a replacement of bone. And then we can also see systemic treatment alone. And you can see this upper line shows that the kyphoplasty helped to keep these vertebral bodies in the same height, or that they don't fracture any further. The problem is, and that's still a discussion, and there's more an opinion debate, if the other vertebral bodies, because this one vertebral body is stronger, if the other vertebral bodies have a high risk to fracture, that's unfortunately unclear. But for pain management, a lot of patients have a really good benefit from a kyphoplasty. And again, the summary here, we need to test. We need to test for calcium. We need to test for other markers in the blood to figure out if a patient has bone disease. Obviously, radiological imaging is very important. And I mentioned that MRI shows the bone marrow involvement, CT and PET-CT show the bone involvement. Then the treatment is bisphosphonates or denosumab, which are two different approaches with a similar end effect. We recommend calcium. I completely agree with you, Beth. As soon as a patient is on zoledronic acid and or denosumab, or denosumab, then they should also get calcium and vitamin D. And my practice is in Buffalo, New York. We are not really tortured with too much sun. So we do need vitamin supplements, and my wife and I take them too, even though we have no myeloma yet. Nutrition, there's no really good recommendations for that, but obviously calcium can also be, there can be an uptake of calcium as well with cheese and milk products if they are tolerated. And then functioning, obviously we have to make sure that we keep our patients active, and I will talk about that a little bit more in detail later on. Emergency, obviously, new pain in an area where there was no pain, or severely more pain in an area there was pain before, is of course an alarm sign. Back pain is unfortunately the most common one, and the changes in mental status can be a sign of hypercalcemia if the calcium is too high. I mentioned that's coming out of the bone as well, is also related to the bone disease. Constipation, nausea, vomiting in very high calcium levels, that can be a symptom. Falling is obviously a problem, and when the patients have very high calcium, that can also be a risk that they lose their balance. And I think, I go on with the physical activity. And because I saw that some patients also asked this in the chat, should I be physically active? The answer is yes and no. So a long time we told patients, because of the risk of fractures, please don't do anything, don't do any sports, like sit on your couch and don't move, right? And that's what I did initially, because I was afraid that the patients get more fractures, which is of course horrible, and I want to avoid that. But these images that you see here are images of astronauts. And as you know, when astronauts go into outer space, they are not exposed to the gravity of Earth anymore. So their bones, they actually get osteoporosis. And I mean, those guys and girls, of course, too, they are in the best shape you can imagine. Those are really very well-trained individuals, and they get bones like a very old and very sick person. So they have to do very sophisticated training, because gravity is something that keeps our bones strong. So we know that we need resistance for our bones to grow. And one patient asked that in the chat. Of course, it's very important that you don't do weightlifting if your bones have a fracture risk, and that's where you have to really talk very closely with your interact closely with your provider. But in general, this question was, is strength training good? Yes, strength training is good, but it has to be supervised. It has to be very, very careful. And just one trial that I picked out of many, running that was actually in rats. So they gave rats myeloma or weakened their bones, and then they let them run, swim, and they had a control group that did nothing. And they found that running, this impact and the effect of gravity was very helpful. But running is also a risk for fractures in the spine. So please talk with your doctor before you do any of these interventions. But in general, it's right. And here you can see a big lytic lesion. If this patient gets more impact on their spine, that can lead to a fracture. And therefore, please talk with your doctor. I cannot, or nurse practitioner, physician assistant, whoever is in reach, please ask them before you do any exercise. But aim to do exercise, aim to be active. That's very important.
And back
then I
to
hand back
me.
to you. Yes.
I just have 2 more slides. We really wanted to make this just a brief presentation to have so much time left. We have such wonderful questions. I just wanted to highlight and echo everything that Dr. Hillengass had said. Years ago, we really restricted therapy. We used braces to brace the pain instead of now we have an internal cast with the balloon kyphoplasty, which can help prevent that and treat that pain and radiation, and then systemic therapy. But what else can you do? Physical therapy is often recommended by insurance companies, but I don't think many people take as much advantage of it. It can come to your house if you can't leave. You can go in a swimming pool if you don't want to do land exercises, but learning the right exercises to do, because some people say, oh, I'm so active, but learning the right exercises to strengthen the muscles to support your spine or reduce the hip pain through the appropriate exercises is important. So discuss the physical activity with your provider. Try to avoid an inactive lifestyle. Maybe you have to set your timer and go around your apartment or your room for 5 or 10 minutes at a time, twice a day. If you continue to build on that activity, then all of a sudden you've reached the main cardiovascular recommendations for the daily exercise. Don't exercise, though, if you don't feel up to it. If you're suffering from anemia or you just started a new treatment, be kind to yourself, listen to your body, and maybe take some breaks. Always plan to try to be active, even just sitting up and getting out of the chair works those large muscle groups and helps to keep you fit. Trying to do a few stairs at a time also works those large muscle groups to keep you healthy and active. Try to avoid the public gyms and pools if you have a lower immune system, but if you have a good immune system or you're protected or you're protecting yourself, then definitely try to go about that. There are numerous resources, as you know, available at the International Myeloma Foundation. They are free. The IMF info line, if we don't get to your questions during this, feel free to call 1-800-452-CURE from 9 a.m. to 4 p.m. Pacific Standard Time. Visit myeloma.org, listen to IMF TV conferences, and get the newsletter. All of these are important things to consider if you're living with myeloma, to live well with myeloma. I think at this time, I thank Dr. Hillengass. He's going to stay on for questions with me. How do you think we should do this, Dr. Hillengass? Should we start from the top and make sure we've hit all the questions?
That was exactly what I was thinking, yeah. And we can just take turns if that's okay for you.
Perfect. And
so I already started. Yeah, it started with the imaging. I think most of them responded to MRI sensitive, not available in all areas, but you should be able to reach someone who has access to that. Bone lesions can heal. It takes very long. They usually, because it's the scar, oftentimes they don't completely disappear. I have seen patients where the lesions completely disappeared when they were small, but it's unfortunately not a guarantee. We have to get even better with our treatments so that the body has more time to heal. I think these are the most important factors there.
Great. And then I think it's really important to, this one question, how is myeloma bone disease different than bone tumors that represent metastasis and other kinds of cancers? Again, it's the makeup of the cells and the chemicals that are secreted by that tumor in many ways. Again, the myeloma is that two-way interaction between the myeloma tumor cells and the bone marrow microenvironment where the healthy, where the plasma cells and the healthy cells live. And so through that two-way interaction, metastases occurs. But based on the makeup of the tumor, they can cause what's called sclerotic lesions in certain cancers of solid tumors. But again, that bone, it varies according to the type of cancer, the lung, the breast, or the prostate, etc. Dr. Hillengass, do you have any more insights to share with that topic?
No, it's some are growing bone, some are dissolving bone, and mechanisms are similar, not exactly the same, but yeah, not exactly what you said.
I'm going to point this question to you, Dr. Hillengass. I get this all the time. The primary care providers want bone density screens in myeloma, and they're on bone builders. and we know they have lytic disease. What do you tell your patients?
Yeah, so as I mentioned, the DEXA scan in myeloma is very challenging because it doesn't really reflect what's really going on. The DEXA scan is very good for diffuse bone loss. And to be honest, our dexamethasone, our beloved steroids that most patients hate, is unfortunately has as a side effect, as a long-term side effect, bone weakening. But we use the denosumab, or we use the zoledronic acid to counteract that, and the calcium and the vitamin D. So I don't feel that DEXA scans are very important. If there are other reasons like hormonal changes, postmenopausal, that's a different question. But then again, it is not enough to do that for the myeloma itself. One brief question about sugars. I personally don't feel that patients have to cut out sugars, because it's like when I would smoke a cigarette and tell them to stop smoking because I love sugar. I mean, I love cookies. So that's my team knows that already. So they tease me with that. Now, you don't have to avoid sugars, but you should definitely eat healthy. You should have a high plant-based diet with a lot of plant-based products. But to completely avoid sugars, I don't think is necessary. We do some studies at Roswell Park right now where we do intermittent fasting, but that's a different approach and has not really anything to do with sugars. What do you think, Beth? Patient has hypocalcemia and cramps. They're post-transplant. I personally think that might be the Revlimid. What's your experience?
Absolutely. They're likely on Revlimid post-transplant. Again, you might be on bone strengtheners and not taking calcium supplements. So discuss this with your treating physician, your treating team, and maybe you can have some additional testing. So there is also hormone changes that can occur after transplant or just for any reason. So checking thyroids, parathyroid, and other hormones might be a good idea. Another question, I think we had answered this, Dr. Hillengass actually looked like the bodybuilders, and there's a heavy weightlifter that likes to strengthen bones, and is there any reason why I should be concerned? And that's an individual discussion. I've had people with very strong bones and very strong spines in excellent remission who've always worked out, and I will oftentimes clear them for lifting moderately heavy weights. And I know I might get in trouble for saying that, but it's a discussion with the treating team. It's taking into account that individual person. And if that is where you find your joy and you really want to be a heavy weightlifter, we work with the orthopedics, oncologist, and the patient to discuss the risks and benefits and protect you the best way we can with bone strengtheners. Dr. Hillengass, what do you think? You can disagree.
Yeah,
it's
absolutely.
Okay.
Yeah, again, be careful, but we have seen, we are doing a trial where we do actually resistance training with our myeloma patient, and this patient who asked actually has smoldering myeloma, no bone lesions. So there's even less concern, but we have not seen any patient having any harm, but my wife is the personal trainer and she's supervising them very strictly. So that's very important. The technique is very important. Knowing which exercises are okay, which are maybe dangerous, that is very important. And please stay in touch with your providers. Then there are questions about PET scan and kidney damage. Not a problem. The PET scan, the dye that we use in PET is not a problem for the kidneys. In case of CT, we really want to avoid CT dye because that is not good for the kidneys. With MRI, if the kidney function is good, it's not a problem. If the kidney function is impaired, then we should not give MRI contrast agents because they can cause longer-term bad effects on certain systems in the body. So PET scan, not a problem. MRI with good kidney function, not a problem. But with bad kidney function, don't do it. And CT dye, if you can avoid it, please avoid it. There are some situations when it's about a pulmonary embolism, for example, you need the dye. That's important. But if it can be avoided, let's not do it. And PET MRI, as someone is asking, that's not very well investigated yet. It has obviously the benefits of the MRI with the sensitivity and of the PET with the information about the metabolism, but it lacks the information about the bones. And we are talking so much about the bones. So the CT is the best technique for the bones.
I agree. We use the PET CT and feel that that's the best for the bones. But as you'd mentioned, the MRI is so helpful. We have these high-risk smoldering studies, and it's included that you have to have the PET CT, and then if that's negative, or the whole body scan, and if that's negative, then you have the whole MRI. And sometimes we find lesions, but usually if you have a good PET CT scan, I think a majority of people will have a negative MRI findings, which is good news. I'm going to skip over to what can patients in the MGUS stage do to improve bone health. Exercise, exercise, exercise. Weight-bearing exercise, I'm going to steal that about the rats and how when they ran, that helped to build the bone. I think walking is a very good exercise as well. And there are some other studies that show that weight-bearing exercise can include swimming. So you have to do a lot of swimming, but swimming can be considered a weight-bearing exercise if it's done right. Dr. Hillengass, what do you think?
Yeah, absolutely. 100% agreed. That's what we have to do. And that's why I showed the astronauts in a myeloma talk. So that's definitely important. There's many questions about how long do we somata, and Beth, you mentioned that we don't really know. What we currently do, just based on experience, not on science, is we stop after 5 years if the patients are still in remission, because we know that especially zoledronic acid stays in the system for a very long time, so that it stays in the bone, and it still has this effect that we talked about. At one point, there is a risk. I had one patient after 10 years where this kind of slowing down of the bone turnover led to actually fragility of the bone. So the bones actually were more fragile than they were without. But that was after 10 years in complete remission. So in this patient, we should have stopped earlier. And unfortunately, sometimes we learn by doing that, or by making mistakes. The osteonecrosis of the jaw is obviously a problem. I personally am very hesitant to restart the zoledronic acid. I'm not sure, what do you do, Beth?
We do not restart zoledronic acid if you have an osteonecrosis of the jaw episode. We also do not give denosumab. I optimize the calcium and vitamin D. We encourage weight-bearing exercises, but we do not restart it. So yeah, I agree. Yeah. There's a question about a class. I think that refers to reclass. So there are a lot of different names for similar drugs. Reclass is the FDA-approved treatment. It's zoledronic acid 5 milligrams on a yearly basis, and that's given for osteoporosis to postmenopausal women. It's approved for, but for somata or zoledronic acid, that's 4 milligrams, and that's given monthly. Just like I saw in the chart, one of the respondent questions was they wanted to know if denosumab was daratumumab, and no, they're two different things. But denosumab is the same as Xgeva and Prolia. Again, it's what it's approved for by the FDA as to what that trade name is, and I apologize for the confusion. But on the IMF website, you can see the list of all the drugs if you go to myeloma.org under resources. Would you like to take the next question?
Yeah, I'm scrolling through some of them we already mentioned, and I think because there are 38 new messages, so I think we have to pick up speed here. Dose of calcium, I say between 500 and 1,000. Do you agree? That's usually what we do.
The World Health Organization has recommendations for if you have osteopenia on bone density or osteoporosis. And so that kind of varies, but we look at the prescribing information for the drugs. So for on the denosumab, it's so funny. I have people I work with, the doctors, they say, oh, just take a couple of Tums on the day of the treatment, which equals about 500 milligrams of elemental calcium. You can chew it, so it's not an extra pill. It's relatively inexpensive, but I find that the calcium can really drop down low if you have effective control of the myeloma. So you have to be very careful about low calcium levels. You can get this tetany and it can cramp up and be very uncomfortable.
Yeah, there's another really good question that I would like to answer about why would a patient who has no osteolytic lesions still get somata from zoledronic acid or denosumab? So the point is what we mentioned with these very complex graphs. The problem is that the myeloma cells stimulate the bone-eating cells, but the bone-eating cells get substances out of the bone, kind of nutrients that feed the myeloma cells. It's a little bit too easy, but it's unfortunately what's happening. So that's a vicious circle. And to break through this vicious circle, we kill the myeloma cells with our treatment, and we kill the bone-eating cells that are too active and too many. They're not sick by themselves; they're just too many and too active. We kill them with the bone-limiting drugs or the bone turnover-limiting drugs. There are different ways to say that. I would say it's still important to get the zoledronic acid, and it's also what the guidelines say. So I would still recommend that.
100%.
Other important questions here.
There was one about 3 compression fractures and 2 were treated with kyphoplasty. Then a third was found and they were told they were too old. I think we still try to focus on fitness and frailty. And sometimes people are very sick from the fracture and in a lot of pain. And so one of the cutoffs, though, in my institution is the height. So you worry about that leakage. So it's polymethyl methacrylate is the cement that's often used, and it's the thickness of like soft whip ice cream. So it tends to stay in that cavity, pardon me, but unfortunately, sometimes it can leak out. So many people that do the procedure don't want to go too high up in the spine, into the cervical spine or the thoracic spine. So sometimes it's the location, and I would have that conversation with your treating team as to really why. And age should not necessarily be an issue unless they're really worried about anesthesia risk associated with that outpatient or short stay procedure. I don't know what your thoughts are.
Yeah, no, yeah. Absolutely. I found some questions about MRD, about treatment, and those are really important and really good questions, but I think that would really go far beyond our bone talk today, and I'm sure there will be very good talks, and maybe they are already online where you can get answers to these questions. So I would like to stick to the bone and imaging questions. There's the question, after a patient is in remission after stem cell transplant, should they get another PET scan? Should they not get one? Our recommendations is to get yearly PET CT scans. One reason is that obviously when we had some patients where the disease came back without any production of monoclonal protein in the blood or urine. So the imaging can be very helpful. We should not do it too often, but once a year I think is reasonable, or maybe every other year if a patient is in remission for a longer period of time. And unfortunately, a lot of our drugs can also cause secondary cancers, and the PET scan helps us to identify those cancers early. Not all of them, but some of them. And so that's another reason why I personally prefer to do PET scans, if possible yearly or maybe every other year. What do you do in Cleveland?
So it varies. So one of the challenges we have in my institution is that, as you mentioned, skeletal surveys have been the standard of care. Those are plain x-rays from head to toe. They're easy to obtain. They're relatively inexpensive, but unfortunately you have to have anywhere from 20 to 40% bone loss, depending on what study you look at, as to whether or not you have damage to the bone or not. And so we have these people that for years we've getting regular bone surveys because that's what the guidelines used to recommend. Now what do? Do we do a whole body low dose CAT scan to better understand where the disease is? Or do we do a PET CT scan? What do you do for your patients that have been in remission for years, Dr. Hillengass? Maybe you can answer my question.
Yeah, so we, as I mentioned, we do PET scans once a year. It might be a little bit of an overkill, but we're also looking what the outcomes will be, if that is really helpful. And again, in individual patients, it helps. In other patients, I mean, it's also radiation exposure. It's not super much, but it's still there. And if we do that for a longer period of time, and we hope that our patients live very long. So what we have done now is that we do a PET CT, and then we switch to MRI, because MRI has no radiation exposure, which then can be beneficial. But we are privileged that we have this whole body MRI with this diffusion weighted imaging. So that's something that we can do. If the center where you are being treated can provide this, that's definitely also a good option. And because we would see changes there also before we have actually the bone destruction. To be completely honest, we did an analysis in smoldering myeloma where we did every 6 months MRIs, which was very sensitive. And still some patients in these 6 months in between developed a new disease. So we cannot do MRIs before and after meals, even though I would love to do that. So there are limitations, but of course, the more we can do on the safer side, we are.
Great. Another question that came through is, I thought myeloma can cause hypercalcemia, and now you're telling me to take calcium supplements. I'm confused. And so, again, what you're doing with these medications, these bisphosphonates or the denosumab, the bone building drugs, you're taking calcium from the bone, from the blood, and putting it back into the bone to strengthen the bone. So the blood calcium goes low as you're rebuilding the bone. So if you are in a remission or your myeloma is under control, you will not have hypercalcemia. We need to give you calcium supplements. Again, have this discussion with your treating team, but the goal is to, because your blood calcium will go really low on these bone building drugs. So have that discussion with your treating team. And what do you think, Dr. Hillengass, about vitamin D? I very much believe in checking vitamin D levels and replacing vitamin D if it's low. Is that something you do, or do you have a team of people you work with, like primary care doctors, endocrinologists? Who does that in your practice?
We don't do it on a regular basis, but we definitely do it at first diagnosis, and we want to replace. We know that in our area and your area, which is not so far away,
3 hours away,
we have a chronic vitamin D deficiency. It can be checked, and we work together, as you mentioned, with our primary care doctors in the community, and they can help with that as well. So I think this definitely makes sense, because we should, especially our myeloma patients, should protect themselves from too much sunlight, but then on the other hand, keeps them from building their own vitamin D. So that's a little bit of a problem there. So therefore, we recommend to check the vitamin D levels and to definitely replace vitamin D.
Excellent. Well, I want to thank you, Dr. Hillengass. I think I'm going to turn it to Robin. I really wish we could have answered all of your numerous questions in the chat. Please feel free again to call the 1-800-452-CURE if you have additional questions. There's also additional great resources on myeloma.org website for patients, prior videos, and there have been other bone health discussions as well. Robin, are you still there to close out our call?
I am, and I've been sitting here listening with both ears. The two of you have been amazing as always. We know that bone health is so important, and to learn how and when and what to do, and to have these better conversations with our healthcare team so that we can each make the best decisions for ourselves. So I'm sure everyone on this call is grateful, and there's even so much more we can delve into, I'm sure, as far as bone health. And Dr. Hillengass, you had said that there are questions in the chat there that were outside of bone health. And I just wanted to share with everyone, on this Saturday, believe it or not, we're having another webinar, and that is going to focus on a much broader scope. And Beth, you'll be joining us again for that on Saturday. So if you didn't get enough tonight, come on back and so go to myeloma.org to see how to register for the Saturday presentation is, and you will learn even more. So for tonight's program, we'll wrap it up and thank our sponsors again. That's Bristol Myers Squibb, GlaxoSmithKline, Janssen, and Sanofi. And please don't forget that we tried to answer your questions, and they did such an excellent job. But if you still have questions, don't forget the IMF info line, 1-800-452-CURE. Missy, Paul, and Deborah are happy to take your calls. And we thank you again for taking the time to join us to learn more about bone health, to help you live well with myeloma. And thank you so much, Drs. Faiman and Hillengass. This is such excellent and much appreciated information. So thank you, and I wish you all a good rest of your day or evening.
Thank you very much, everyone.
Bye-bye. Thank you.